is still a disorder characterized by high morbidity and mortality. And we all hypothesize that elevated levels of antepartum activin A can lead to late postpartum cardiac dysfunction in women with hypertensive disorders in pregnancy. So to enlighten us upon this topic, I would like to introduce Dr. Sajid Shahul. He's a certified anesthetist and critical care medicine specialist in Chicago, and he will deliver a talk to us through webinar.
Hi, Dr. Shahul, can you hear us?
Yes, can you hear me?
Yes, sir.
Yeah. You can go ahead, sir.
Oh, great. Thank you. It's a great privilege to be here in the morning. So I'm going to talk about Activin A and postpartum cardiac dysfunction. So the outline of my talk is going to be cardiac assessment in preeclampsia. We'll discuss some new evidence from our group. And the goal for this talk is to focus on theragnostics, which is early diagnosis to guide therapy. So let's talk about a real case. We have a 34-year-old female, postpartum day 16, admitted to the ICU with severe hypotension and pulmonary edema. Her pregnancy was complicated by severe preeclampsia. On admission to the emergency room, she has a cardiac arrest. So when we looked at her echo, this was her echo for 4 weeks before. And this is our echo now. So this is the parasternal long axis view.
Doctor, your slides are not moving, doctor.
They're not moving?
No. Can you just move a couple of them?
They're moving for me.
No. Can you just stop sharing and then share again? Yeah.
Okay.
Can you just start sharing?
Sure.
Yeah, now we can see.
What, is it moving now?
Just put it on show. Yes. Yeah.
Yes, it's moving. Thank you.
Great.
Yeah.
Okay. So we're discussing this case of a postpartum lady who has a cardiac arrest on admission to the ED. So when we look at her echo, we get an emergency echocardiogram. This was her echo 4 weeks prior. I want you to focus on the left ventricle. Here you can see that the left ventricle is completely normal. There is some amount of subclinical dysfunction, but she goes to complete heart failure within 4 weeks. So you can see this is the left atrium, left ventricle right here. Same thing here. This is a normal EF right here. This is the left ventricle, right ventricle on top. She goes to completely abnormal EF with an EF of 5% within 4 weeks. And we do not know why this happens, why this transition happens in these women from a normal EF to a very low EF within a substantially short period of time. Same thing, this is the parasternal long axis, apical four-chamber view, right atrium, right ventricle, left atrium, left ventricle. Again, this is the left ventricle right here. You can see that the left ventricular dysfunction, again, becomes extremely low with a very short period of time. So this is how peripartum heart failure presents, or peripartum cardiomyopathy. So when you look at progression of heart failure, right, the world's research is now focused on subclinical cardiac dysfunction, which is asymptomatic, to clinical dysfunction, which is symptomatic. So you go from symptomatic, asymptomatic heart failure to symptomatic heart failure. Why is this important? Because the odds of dying becomes 9 times higher when you go to symptomatic heart failure. So the goal is to find patients who are asymptomatic and have subclinical cardiac dysfunction. Now, why does this matter in India? Because this is why I do a lot of this research specifically for the Indian audience, because the burden of heart failure in India is around 5.4 million. So worldwide is 100 million. Mortality in India from heart failure 1 year after diagnosis is 23%, very high. The mean age of heart failure diagnosis in India is 10 years younger than the United States and Europe. The mean age of heart failure in India is 59 years. And this is most important. Nearly 50% of women in India are at risk for cardiovascular disease. So hence, we need to find subclinical disease, because once we find it, we can treat it early. So if you look at maternal mortality, right, cardiovascular disease, in the United States at least, cardiovascular disease accounts for more than 33% of all pregnancy-related deaths in the United States. 20% of all these deaths are from cardiovascular disease. Why is this important? Because there's considerable morbidity and mortality from cardiovascular disease. And 1 in 3 ICU admissions is during the pregnancy or the postpartum period. But 25%, so more than 1/4 of these deaths from cardiovascular disease are actually preventable. So if you get to them early, diagnose them early, and treat them early, perhaps the outcome can be improved. So how often does heart failure present? For this, we use large national readmission databases in the United States. These are databases which have 21 states here, 2,000 hospitals, 14 million patients. We found that among preeclamptic women who have around 6.9 million discharges, we looked at the 90-day readmission rate. We found that the 90-day readmissions, if you're normal, is around 1.5%. If you have hypertensive disorders of pregnancy like preeclampsia, it's 3.6%, almost 3 times higher. Among these women who get readmitted, this was striking. 7% of them come in with new onset acute systolic heart failure. More importantly, again, this represents the burden of cardiovascular disease that's increasing. Even if you're completely normal, 3% come in with acute systolic heart failure. What this represents is pregnancy as a stress test. Even if you're completely normal, if you have cardiovascular risk factors, perhaps you can be admitted with acute systolic heart failure. So again, this was very striking data. 7% of women who are readmitted have acute systolic heart failure, who are completely normal during their pregnancy. This is de novo heart failure. So who are these women and when do they get readmitted? If you have heart failure readmission, it comes in sooner. You get a readmission within 12 days, your length of readmission is longer, and you have more, the price is higher for the readmission. So it's 12 versus 22, 3.3 versus 3. So you have a longer stay here and you get admitted sooner. So the question is, how do we find subclinical disease? And this is much of our research has been focused on this. So if you understand the heart right now, the heart contracts. It's actually we now understand there's a 3-layered spring. The spring contracts, there's ejection of volume. In diastole, there's relaxation. The spring recoils outwards, and there's filling of the ventricle. So this is how the cardiac contraction is. But we've changed our understanding of how to diagnose cardiac dysfunction. Previously, we just used look at ejection fraction. How much does the heart move between systole and diastole? So we look at displacement and velocity. Now we look at each point in the ventricle, does it move relative to itself? And that is called strain. So deformation is change in length, and the relative amount of deformation is called strain. This is a very effective and very efficient way to diagnose subclinical heart disease. So if you have a normal EF patient, right, and if one part of the ventricle is moving, it pulls along the part of the ventricle that is not moving. That's tethered movement. But if you look at strain, it is relative motion to itself. So again, this is what strain is. You put a point in the ventricle, right, each point of the ventricle, and see whether it moves in. So strain is excellent at detecting subclinical disease, and particularly differentiates active versus passive contraction. So you put a point, right? It's frame by frame tracking. So you can track every point in the heart relative to self. So for example, in normal, when you look at the EF, right, if this part is moving and this part is not moving, it gets pulled along with it. So this is frame by frame tracking, and that's what speckle tracking is. So we actually looked at this. This has been studied. This is one of the first studies that we actually did, where we looked at strain in patients with preeclampsia compared to patients who are normal or have chronic hypertension. We found that despite having a normal EF, again, you can see the EF is 55, 57% here. No difference between the groups. Strain, a normal strain is -20. A value of -19, -18 is abnormal. You can see that patients with preeclampsia have a lower strain compared to normal. So anything greater than -20. So you can see it's -23.9. So a normal strain is higher, a lower strain. Despite having a normal EF, they have subclinical cardiac dysfunction that wasn't picked up, but strain actually picks it up. So preeclamptic women have subclinical cardiac disease that can be picked up now with advanced echocardiography. So if you go back to our patient who had a cardiac arrest, she had a normal EF, you saw that. But when we did the strain analysis, you can see this number is minus 17.1. It's less than minus 20, so it was a very abnormal strain that we didn't know about. So she was walking around with subclinical disease, but since she was completely asymptomatic, we couldn't find the problem. So, what causes this cardiac dysfunction? And this is what we've been focused on for the last 5 years. What causes this? What changes in a woman? So, this is what we're thinking is happening right now. If you're preeclamptic, you have oxidative stress. Oxidative stress releases activin. Activates the ERK pathway that causes fibroblast proliferation in the heart, which causes myocardial fibrosis and remodeling that causes cardiac dysfunction. So we've proved much of this pathway. So we think much of the cardiac dysfunction is mediated through as activin A, because preeclamptic women have very high levels of activin A that causes myocardial fibrosis and remodeling. And strain actually picks up myocardial fibrosis and remodeling. So we actually looked at this. We did longitudinal studies in women who are preeclamptic and followed them out from their pregnancy. And we looked at echoes 6 weeks, 6 months, and 1 year out. So this is postpartum normal. So what we see is even if you're 6 weeks out, there's a decrease in strain. We actually looked at global longitudinal strain. We saw there's a persistent decrease in global longitudinal strain that remains in preeclamptic women, even 1 year out. We actually have data on this. Women for 10 years out, we see persistent decrease in strain. So again, you can see right here, the small gray bar graph, right, is going down. So we see there's persistent decrease in cardiac strain among preeclamptic women. We also looked at activin levels in these women. We find that that among preeclamptic women, activin levels keep going up. So postpartum, right? This is postpartum. This is the once they've had the baby. There is no reason for this to go up, but this keeps going up. We now know why this happens too. This likely happens because of macrophage activation that takes place in these women. So can you predict? This is the holy grail. Can you predict cardiac dysfunction antepartum? So we did this. This was a study of 85 patients that we did, observational study of preeclamptic patients, where we drew blood in the third trimester and correlated that with postpartum cardiac dysfunction 1 year out. We found that higher levels of activin during the third trimester predicted postpartum cardiac dysfunction using strain. So this was the study. We had a normal patients of 25 patients. We had patients with chronic hypertension and preeclamptic patients. Again, as expected, right, there was no difference between the ages. But as expected, preeclamptic patients had a higher BMI, body mass index, versus the normal patients. And the BSA was completely normal. But again, when we looked at it in the third trimester, this is what we found. Global longitudinal strain 1 year out among preeclamptic versus normal. Normal have normal strain, but preeclamptic women have decreased strain, minus 17.76. The ejection fraction is completely normal, but you can see they're walking around 1 year after delivery with subclinical cardiac disease. Everything else in the heart is normal. The left ventricular end diastolic volume is normal. The stroke volume is normal. What you can see is because of the hypertension, they've increased septal wall thickness. So this is the ROC curve. This is the prediction of cardiac strain 1 year out, looking at antepartum activin. So during the third trimester, you see antepartum activin right here with the clinical characteristics predicts cardiac dysfunction with a C statistic of 0.93. So very high prediction of cardiac dysfunction postpartum. So this is coming. So you can predict which women will actually develop peripartum heart failure later in life by looking at activin. And to find subclinical cardiac disease, the goal is not to let them go into heart failure. you can use myocardial strain. So we also correlated activin levels with postpartum diastolic function. As you can see that as the activin levels go up, the diastolic function gets worse, the mean arterial pressure gets higher, and and the LV mass index gets more. So again, all consistent with abnormal morphology in the heart uh, going on, and that is likely driven by activin. So, can we do anything to prevent postpartum cardiac dysfunction? We think we may have a solution. Aspirin inhibits the pathways that are activated by strain, the ERK2 and the AKT pathways. So, we actually did a study looking at women who receive active aspirin during their pregnancy and looked at Activin A during their pregnancy. Uh, so around this cohort was actually 38. We actually have much more data now. We find that the mean activin levels among patients receiving aspirin is higher than patients receiving saying aspirin during their pregnancy. It's 10 versus 7. So again, so you have lower levels of activin if you're receiving aspirin during your pregnancy. And this translates into improvement in longitudinal strain during your pregnancy. Again, if you're receiving aspirin, your strain is minus 19. If you don't, it's minus 16. Again, the subclinical heart failure that myocardial strain detects. So that is the summary. So this is where most of our work is. We find that antepartum activin levels can predict postpartum cardiac dysfunction. We show that if you follow activin levels, it correlates with ongoing cardiac dysfunction. So we can use this as a biomarker for increased surveillance to prevent morbidity in these women. And postpartum aspirin actually is an emerging viable therapy right now. So thank you very much, and I'm happy to take any questions.
Thank you, sir, for your valuable time. Now the topic is open for discussion.
Dr. Shahul, that was a very lucid talk. This is Dr. Revati. I just wanted to ask you one question. I mean, it's a very interesting revelation that you're able to predict postpartum cardiac dysfunction using a marker, Activin A, so that it's easily reproducible, because earlier we were just relying on the echos, and echos may not be so easily, it can't be performed so easily antenatally, repeatedly. So the question is it only aspirin, or did you also find some difference by using beta blockers in patients who are predisposed to such kind of cardiac dysfunction antepartum?
Oh, that's such a great question. So if you have symptomatic heart failure, the treatment is using beta blockers and angiotensin receptor blockers, ARBs, etc., to prevent myocardial remodeling. So in stages when you have subclinical heart disease, we were focused on activin blockade. So they've actually, in mice models, when we give activin blockers, we are able to completely reverse cardiac dysfunction. Beta blockers doesn't do it when you're subclinical disease, but you're in clinical disease, it is absolutely indicated, yes.
So most of these patients are on aspirin, they're on labetalol. So will that add on to minimizing the risk of postpartum cardiac dysfunction?
Absolutely. Like your previous speaker said, right, that there is hypertension is there. And much of this is the heart failure is driven by diastolic heart failure. But we, in our models, when we accounted for the hypertension, there was an independent risk factor for heart failure among these women, despite the hypertension being treated. So labetalol definitely is absolutely indicated here, because there's diastolic heart failure, that component can be treated, yes.
Do you have any more questions?
Any other questions?
Do you have any other questions?
So thank you very much, Dr. Sajid. This is Dr. Kamini Rao, chairperson for this Congress, and it's a pleasure to have you at 4 a.m. in the morning and still smiling. I think that's really good because...
Very good. I'm glad you guys are doing such great work there. Very nice.
Yes, and also, are you an early riser?
I am. I am very much. So this is very good. This works for me very much. Yes.
Oh, thank you very much. It's been a pleasure having you here. And do we have any more questions in the audience? They're all here post-lunch, so they're more into a hypotension state, I suppose. But however, I will then hand over the mic to the hall in charge. You take over now, and thank you very much, Sajid, for your presence.
Dr. Rao, it's my privilege. Thank you very much.
We'll now move on to the panel discussion. The decision to start thromboprophylaxis during pregnancy is sensitive to women's values and preferences, but the inappropriate usage of thromboprophylaxis will lead to catastrophic events. Hence, I call upon different faculties to enlighten